Welcome to Therapy Café, the future of mental health, episode 6. Everyone is part of the solution, the Zero Suicide Framework, with our guest, Dr. Julie Goldstein Grumet, a clinical psychologist and leader in suicide prevention. Many of you have likely heard the statistic that over 30% of individuals who attempt suicide have visited a healthcare provider within the week before their attempt, and 83% within the preceding year. This is highlighting a missed opportunity for intervention. Yet, despite this, fewer than half of healthcare providers feel fully equipped to care for at-risk individuals. Today, we're going to have a really interesting discussion of how Zero Suicide aims to bridge this gap by taking an evidence-based system approach to suicide prevention. We'll also focus on strategies that mental health practitioners can incorporate into their practice for clients at risk of suicide. Just a reminder, at the end of the podcast, we'll provide information about how you can obtain continuing education for this course. Also, ensure you never miss an episode by hitting the subscribe button. Here's my conversation with Dr. Goldstein Grumet. Hi, everybody. Welcome back to another episode of Therapy Café, the future of mental health. Today, we are here not only with an industry expert, but with one of my friends. Dr. Julie Goldstein Grumet is Vice President for Suicide Prevention Strategy and Director of the Zero Suicide Institute at the Education Development Center, the EDC. Dr. Goldstein Grumet integrates comprehensive suicide prevention approaches across sectors, settings, and ages, and delivers solutions that address shared risk factors to improve long-term mental health and well-being for individuals. She has provided strategic guidance for the establishment and evolution of the Zero Suicide Framework since its launch in 2012. And she leads the development of the resources that enable the effective implementation and dissemination of this framework throughout healthcare systems. Dr. Goldstein Grumet has expertise in behavioral health transformation, state and local community suicide prevention, quality improvement, school mental health, and the use of evidence-based practices for suicide care. She has collaborated on numerous grants and publications about systems-based approaches to suicide prevention and is a sought-after speaker. Dr. Goldstein Grumet has a PhD in clinical psychology from the George Washington University. Welcome, Julie, to the show. We are so happy to have you. So just as we get started, for our listeners, help us understand, why did you choose to specialize in this area and why are you passionate about suicide prevention?
Yeah, thank you so much for having me. I've been in suicide prevention for like 25 or so years. I know, because I look, 28, so I totally get that. But my dissertation was on suicide prevention. At the time, I was learning about supporting adult women with histories of childhood sexual abuse, and frequently they had thoughts of suicide. And I was just really learning a lot. I was volunteering at the Rape Crisis Center, and so I was really drilling into individual experiences. And then after that, I started working in schools, and a lot of the same risk factors that women had who were adults struggling with thoughts of suicide, I was seeing among kids as well. But in kids and with schools, I really started thinking about systems change approaches and how do you train teachers and how do you build up children to have sort of resilience, social emotional skills, sort of all the things that you want them to have to be successful in life. And I really came to love sort of systems change approaches. I think when you can build in, how do you change the system? How do you measure what you're doing? How do you train everybody to use all of those skills? I think the outcomes can be great. And so as Zero Suicide emerged in healthcare, I was in the right seat to have the honor to get to lead it.
That's amazing. Wow. This is one of those fields where you probably will never know, maybe thankfully, how many lives you've touched and how many lives you've saved. So it's incredibly important work. Can you bring us up to speed on the current stats of suicide? Because you constantly hear this as a moving target and it changes. And sometimes it's, men over 50, or sometimes it's veterans, or maybe can you help us sort of understand, the baseline?
Yeah, I mean, suicide is the 11th leading cause of death in this country. It was the 10th. COVID kind of bumped it off. But really, when you think about something that's preventable being the 10th or 11th leading cause of death, you think about heart disease and cancer and things that if you identify, you treat, and people can often get better. Suicide is right up there. And that we really think suicide is preventable if you can find underlying causes way upstream, like I was talking about with children, or even identify people who are starting to have thoughts of suicide but haven't yet hit the crisis. We do know that about 49,000 people last year died by suicide. It's a lot of people, and it's probably people that many of your listeners know. We have another 1.7 million who made attempts. We know that oftentimes people, they don't necessarily go on to make future attempts, but they are at greater risk. But we also know that over 12 million people in this country have thoughts of suicide. That's a lot of people walking around just feeling highly distressed. And so we talk a lot about suicide prevention, and we do tend to focus on that 49,000 number and driving rates of suicide down. But I think we really need to broaden it and think about how are we helping people to live healthier, better, happier lives, and focusing on all these people who are at risk. White men have the highest rates of suicide just by numbers.
Wow.
But American Indian, Alaska Native individuals have the second highest rate, and that has really held true for a very long time. And while African Americans have had lower rates of suicide just by comparison to other demographics, actually the rates of suicide have risen in the last several years, in particular African American boys. So while rates matter and numbers matter, we also really need to look at rates rising within a population and jump in and see what we can do to fix that. One of the challenges in some of these settings and populations is the research that we have. And a lot of the research that we have is not necessarily normed on Black Americans or on American Indian, Alaska Native. And we really have to take culture into account when we think about the ways in which we can reach people in the language and the customs and the culture that's most appropriate. So there's a lot more to be done. We need a lot more investment in research, and particularly in best practices that can reduce suicide in each setting and not just say it's generalizable and one size fits all. That said, best practices have emerged in the last 15, 20 years, and I'm going to talk about them today, I know. But it is really important to try to integrate what we know works and that the research says works. So both are true at the same time. There are best practices we have to use, and we have a lot more still to learn and invest in.
So it's interesting because it's similar to what we're hearing in all areas of mental health, right? That we only know about what was studied on, and if it was the studies were done on white males, then that's kind of what we know about, and we don't know the impact that it might have on Black females or whatnot. So that's feels a little bit aligned with what we're hearing across the board. But it's good that you're keeping track of that, and hopefully as AI progresses we'll be able to get access to larger aggregate data to be able to make, if we're sharing it, to be able to kind of make some of those bigger decisions. Okay, so I often hear about zero suicide, and I love the name because it's one of those where you just know right off the bat zero suicide what that means. But what does it actually mean? Like, what does it mean in a program?
Well, I love that you love the name, because there are some people who say, "Ooh, what does that mean? If I have more than, zero suicides, am I at risk? Am I going to be blamed?" And I think we have to think of zero suicide the same way we think about, airline disasters, right? We want zero. We don't want to be on the plane that goes down. Nuclear industry disaster. We don't want, the nuclear center to melt or to have a disaster. Even things like patient events in hospitals, we don't, the people you've seen probably signs of, this person's at risk for falls, or wash your hands. These are things that should never happen. We should never leave an instrument in a person after surgery. And we have all kinds of checks and balances to make sure that those things never happen. So really, when we talk about zero suicide, what we're saying is we do want there to be zero suicides, particularly in healthcare. We want people to strive for zero, because when you strive for zero, then you think very differently. I think you can say we want to reduce suicides by 10%, but then you're not really going to throw in all of your the ways in which you organize your systems and your training and your measurement. If you say we're just going to reduce by 10%, if you say we're going to strive for zero, then you really are going to use kind of continuous quality improvement practices and change management practices to get to zero.
It makes a lot of sense. So what can you walk us through the framework? How does it work?
So zero suicide is both an ambitious goal that I was just describing, but it's also a set of best practices. And these are based on a lot of the evidence that works. You have clinical practices that should be used with patients at risk. And that could be any kind of healthcare system: primary care, oncology, OBGYN, mental health, emergency department, when you walk in because you think you broke your leg. The idea being that any healthcare system, setting, individual, sports management, pain management, sleep management, right? Any setting in healthcare can be the right setting to identify somebody at risk for suicide. And then the clinical pieces that you would need to utilize really are screening tools that work, systematic, evidence-based screening tools that you use at every visit to seek if somebody's at risk for suicide. If they screen positive, then you do a risk assessment. What's their level of risk? How at risk are they? What type of treatment plan do we need to employ? And then you need to engage specific interventions to reduce that risk. So, for example, there's something called a safety plan or a crisis response plan, and that is tools for an individual at risk to immediately use to reduce their risk, as well as reducing access to their lethal means. And then you need to treat the person or transition them to care to somebody who can treat them. That package, that clinical cluster, is part of the components of zero suicide: to identify, to engage, to treat, and to transition. And then the package around that is really, how is the organization structured to do those things? Has everybody been trained to do those pieces of care? Do you have leadership that supports suicide prevention as a goal? And will they support training and support best practices and policies? And then are you going to constantly improve and iterate on what you're doing through data collection, continuous quality improvement, and really investing back in that structure to ensure all the pieces of care that I was just describing actually happen across the system all day, every day, with every individual?
So I'm curious, does every one of those different institutions or those entities, because that's a lot of different ones, do they all do the same thing, or is there flexibility in the model, or how does that work?
Yeah, so I think, so to describe zero suicide, it's 7 components: those clinical pieces of care and the organizational pieces of care. Clearly, sports management is not going to treat somebody using evidence-based practices like dialectical behavior therapy or CAMS, collaborative assessment and management of therapy, or management of suicidality, or CBT, cognitive therapy for suicide prevention, right? They're not going to use those, but they can screen, they can decide if the person is at risk immediately, and they can refer to somebody else. So there are different pieces versus an outpatient community mental health setting where you have licensed clinicians and providers, and they are going to do treatment practices. There's somewhat picking of those pieces of the model and the way in which they're going to be utilized within a system. But it shouldn't be, oh, Marjorie, you've talked about suicide, so our conversation is over, and I want you to immediately go to the emergency department.
Mm-hmm.
I think a lot of what we're really trying to say in zero suicide is people can be managed outside of the emergency department, number one. And number two, you want all the providers in that individual's network, OBGYN, primary care, pain management, to all know about your risk for suicide so that they can check in with you. Right? It shouldn't be so siloed.
Right.
Ideally, the electronic medical record is integrated so you're able to see through flags that somebody's at risk, but you also want the individual to share this information with their provider so they can check in. Are you going to your appointments? Oh, you're not? What's getting in the way? How can we strategize on that? How are you feeling? So part of it is each system saying they do have some ownership in reducing suicide in their population.
I I'm so glad to hear that. It sounds like you've thought out so much of this. So you mentioned that there's 7 elements or core components. Can you walk us through those?
So I'll start with the clinical pieces, which is really to identify somebody at risk. So that is to screen them using an evidence-based screening tool. like the PHQ, the Patient Health Questionnaire, or the Columbia Suicide Severity Ratings scale, used at every visit to assess, are you or are you not at risk, and what is your level of risk? Then you use a risk assessment tool, which often people use things like the Columbia. There's also the ASQ, which is put out by NIMH. These are things to assess, how at risk are you? Do I need to be, are you at imminent risk? Or as well as, do you have a plan? Have you ever made an attempt before? Have you made an aborted plan such that you've set things up, but then you backed off and you didn't go forward with the actual attempt? All of that for the individual, the clinician, to determine how at risk are you. So that's the identify element. Once somebody has determined that, we have determined that somebody's at risk for suicide, we want to engage them. We want to engage them in treatment. We want them to come back. We want to offer them hope that I have something to offer you as a provider. Again, whether that's pain management or psychiatrist, I understand what you're experiencing and I can help you. And I want you to know that I'm here and I'm honest and I take your thoughts seriously. All of that is an engagement strategy, and it's part of what we would call a suicide care management plan. What are you going to do? How are you going to keep me engaged? What are you going to do at every visit? And it is the provider who really has to walk the individual through that. They're going to tell them, as part of engagement, the first thing I'm going to do is try to help you minimize your risk through giving you tools to manage your risk, like the completion of a safety plan. We're going to talk about, what is it that triggers your risk? What is it that reduces your risk? What are your own coping skills? How do we have that safety plan be meaningful to you as an individual? And how are we going to reduce your access to lethal means? So all of that is what it's under the umbrella of engage, the third element. The next element is to treat. And that is to use evidence-based interventions that treat the individual, the underlying causes of their suicide. So it's not enough to say, I think once upon a time in mental health and suicide prevention, we used to think, oh, I'll treat the relationship issues, the suicidal thoughts will go down. I'll treat the substance misuse issues, the suicidal thoughts will disappear. And what's emerged over the last 20 or so years are evidence-based practices, CBT, cognitive therapy for suicide prevention, dialectical behavior therapy, collaborative assessment and management of suicidality. Those are things that we know target the underlying thoughts of suicide and actually reduce the suicidal ideation, the suicide behaviors, the suicide attempts. And we need to use those with people. The next piece of the model is transition. We need to make linkages so that people go on to see the providers that we want them to see. We want them to come back. We want them to have next scheduled appointments. We can do that through warm handoffs. I can introduce you, Marjorie, to the provider. We can call them together. What's it going to be like when you go and see them so that you have some preparation? Or what's it even like if we call a crisis line together? But we have to transition people and make sure they go to those appointments. So the clinical pieces are to identify, to engage, to treat, and to transition. The other components, as I mentioned before, are leadership, which is lead, train, and improve, to evaluate that you're doing what you say you're doing.
Wow, that's very comprehensive. And have you, since you've been part of this from inception, have you seen some places really just do it great?
Yes, and nobody's done, right? It's not a journey that you start and then you're finished and you move on to the next thing next month. So there are some systems that have done exceptional work. They've driven their rates down considerably. Centerstone improved their suicide rates by reduced suicide by about 64%. Centerstone's a huge outpatient mental health system across the country, particularly in Tennessee. So we've seen some really great work done in this space. We've seen reduced readmissions to the hospital by getting really quality outpatient care using those evidence-based practices in this bundled, sustained way where they've been able to reduce recidivism and returns to the hospital. So we know that it works, but we also know that it has to be done with fidelity and continuously. It was built off the U.S. Air Force work that they did in the 1990s. They were really looking to do reduce suicide in their system. What they found when they did that in the 1990s was not only did it reduce suicide, but it also reduced driving while intoxicated, interpersonal
Wow.
violence. Because when you think about some of the things that I'm describing, it makes sense that if a person is feeling better, they're less likely to engage in, over drinking or getting
Risky
into
behavior. Yeah.
fights and risky behaviors. But the other thing they found was as soon as leadership kind of said, oh, good, we're doing great, let's like back off because we got a lot of other things to do. As soon as they did that, their rates of suicide, interpersonal violence, drunk driving all went right back to where they were before. So we know that this is not something that it really takes a very sustained effort by leadership and by the people who work in the system to never sort of turn their back and say, oh, I'm sure because there's staff turnover
Right.
or, you think you're doing something and you kind of slide back into old practices.
Right. You mentioned earlier about the evidence, and we talk so much about evidence-based practice. Can you help help us understand or explain, like, how do you get an evidence-based research, and where did it come from, and maybe fill us in a little bit about that.
So, evidence based practices really just mean they've been really well researched multiple times through randomized controlled trials. So, and that they've been applied in different settings by other individuals. So, it wasn't just kind of the luck of the draw by the one research team. Evidence-based treatments are really critical. We rely on them in the medical sphere, right? We know that you take a baby aspirin if you're having heart, you think you're in the midst of a heart attack to reduce the risk of that. And then that practice gets disseminated to all hospitals and all providers. What we want in suicide care is that the evidence-based treatments that have been researched are used with patients at every visit, no matter if you're in Florida or Idaho or New Jersey. And the things that I was mentioning have been researched. So the things like screening, risk assessment, safety planning, treatment, reducing access to lethal means, there's a lot of research that if we really apply those continuously with patients, that they work. But the challenge is that we don't apply them continuously, and a lot of clinicians were never trained to use those
Mhm.
practices.
Yep, another similarity in all areas of mental health consistently that we would find, because that's so much we talk about, and myself too. We don't always learn these things in grad school, or we might learn more about different theoretical orientations, and then as you get older and you're in the field longer, you get further and further away of what's happening. And the way evidence-based practice should work is that as time goes on, you get better and better and more refined on it. I think about cancer, right? Like, you don't treat the same chemotherapy, they get better over time. And we have to do a better job at disseminating and getting kind of that information out to people. So you have some
Wait, can I
hospital.
pause you,
Yeah,
for
yeah.
Marjorie? Because the one thing I think you said is like two things so important. One is like new technology for cancer, new treatments for cancer. Of course, our hospitals give doctors time off and they bring in the resources. They expect that they're going to train their staff in all of these best practices. But one of the pushbacks that we hear sometimes is that in suicide care is that training their clinicians in some of these best practices is expensive. It means time like off the line where they can't bill because they're not seeing patients, or the cost to train people is expensive. And that's not the case in medical fields, right? We expect that people are going to have that, not that they're going to rely on the same training they had in graduate school 30 years ago. But in mental health and suicide prevention, we definitely lean heavily on they're a licensed psychologist or a licensed social worker or a licensed psychiatrist. They must know this stuff.
That's right.
And that's not the case. And I'll give
No.
you like such a great example that comes up because I don't want to forget to say it, which is when I was in grad school, I was trained to use a no suicide contract. Is that what you were trained to
Yeah,
use?
exactly. Yep.
Right. So it's like, hey, patient, you're
Right.
talking about suicide. Please sign this, promising me that you won't kill yourself.
Right.
And then I'll photocopy it and I'll give you a copy and I'll put it in your
Exactly.
chart. But you're not teaching the patient skills to
Right.
manage their thoughts of suicide or their impulse to hurt themselves. There's nothing you can do with that piece of paper. It's not a legal document. It's not a training tool. It kind of maybe alleviated the anxiety of the clinician, but it actually did nothing. And so those have been heavily abolished, but I
Good.
know that there are people still using them today.
Yeah. Yeah. And it was, it was basically, do you have a plan and do you have means to that plan? And yet, what we know now is so much of suicide can also be impulsive, and not always do people have a plan. And sometimes it could be, what if you get so drunk and you crash your car into a wall? It's dangerous, kind of risky behavior. Maybe it wasn't a pure intent of suicide, but it was, is that truly had no suicidal pieces to it? I mean, I think there's probably just so much that's in the gray area of all of this. So when we
Well,
think,
and I think
yeah,
it's fair that that 49,000 number I said is an underestimate because of
yeah,
exactly what you just said. That if we didn't know and they didn't talk about suicide necessarily, or it was impulsive and they crashed their car into a tree, or they overdose on drugs, they may not get classified by the coroner or the medical examiner as a suicide, but oftentimes those numbers are undercounted.
yeah. I'm really curious about the different health systems. So some say, yes, we're going to buy is not the right word. We're going to get involved with zero suicide, and we're going to implement it and get behind it. What's the difference of those that do and don't? Like, what happens if they're not using zero suicide?
What I found, I think, is that healthcare people come into this field because they care and they want to help people feel better, right? That's any mental health or medical provider are doing this because they want people to feel better. I think healthcare systems often think they are doing best care possible to reduce suicide risk. So sometimes I think it's just getting educated about what do we mean, but when we talk about zero suicide, and the best way I think that I can explain the difference is, sure, you might be using evidence-based screening tools and you might be assessing and admitting people sometimes, and lots of systems use safety planning and they make referrals. I think the way I think about zero suicide is the pieces that I just described to you are the bricks, right? There's a brick that's screening and a brick that's risk assessment and a brick that's safety planning, like you're building a wall. And those are the bricks. But a really strong wind or something can kind of knock that over. It's the mortar. Even bumping into it would knock over the bricks. But you have to use mortar to hold those bricks together. The mortar is really implementation science. How do you do those things? How do those things stick in a healthcare system? A lot of healthcare systems use what's called, they are high reliability organizations, HROs. And that really is the idea of when you have a practice that you want to thoroughly embed, bake in, and have it be consistently employed, you have to use all these other things, training continuously, knowing that there's going to be staff turnovers, knowing that you can't just throw a screening tool in an electronic medical record and say it's accessible, because a lot of people don't know how to use the screening tool or they're uncomfortable asking. So they will, and you may have had this experience. I definitely have. You can have the screening tool, but you may have a nurse who pulls it up at your primary care visit and then says, Marjorie, I'm really sorry I have to ask you this, but we ask everybody. So you're not like having thoughts of suicide, are you?
Exactly.
You never think
Right.
about like killing yourself. Things are going okay for you, aren't they?
Right.
When they check off that screening tool, even if it's an evidence-based screening tool, the way it will look in the system is no, 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 right? Check, 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 check. So if you do an audit, the screening tool exists in the record that you were not at risk. But the value of the way in which I did that intervention was horrible. Like, I'm really
Hmm.
not asking you it in the way the evidence shows needs to be done. I'm not telling you I actually want to hear your response and that we're going to have a really meaningful conversation if you say yes. That's the difference, right? The brick is you have access to a screening tool. The mortar
Hmm.
is how do you use the screening tool? Do you understand why it matters to use it as designed? Have I trained you? Have I increased your comfort and your skill? Have I continuously pulled out charts? Have I monitored and done supervision to make sure that it's being done at every visit the way I want? Lots of systems somebody in a healthcare system was telling me recently when they did a chart audit, they found, say, Marjorie, who sees the same number of patients as Julie does, never had anybody at risk for suicide in the last 6 months, where Julie had, 9% of her patients at risk. Now, is it truly possible that none of your patients were at risk and mine were? No. But unless you look at it like that and say, how are you using the tools, or how can I help you? You can't uncover where gaps in training and gaps in knowledge exist. So that's the difference. Why, when a healthcare system says, yeah, we prioritize around suicide prevention, versus a healthcare system that says, no, we've really adopted zero suicide and we think about it very differently. So setting these target goals, meeting the goals, and doing what you can to organize yourself around meeting those goals.
I think that could be a game changer. If you have an entity that is an HRO and they are implementing zero suicide, I mean, that right there is going to make such a huge difference. I believe, and I'm sure the data shows. So I'm sure there's a lot of reasons that we'll get into why that doesn't happen on a regular basis. Let's talk about culture. Does culture play a role in the different sites?
For sure. I mean, I think you can see through everything that we're saying that leaders who really say this is really important, and ensure that training is available and ensure that things are embedded in an electronic medical record, and really prioritize the health and well-being of both their staff and their patients, are going to be more successful than systems who kind of turn their back and say, well, suicide's not a big problem, or what we're doing is fine. Part of the way in which culture really matters is what happens when a suicide event occurs. And do you look for blame and say, Marjorie messed up? Or do you take that on as a system error, that it may have been your patient, but something was missing from the way in which our system trained you, supported you, and it was bound to happen. And unfortunately, it was on you. And it really is the difference between a shame environment and a no blame culture, or a just culture. And in a just culture, if you think about like sending a car out of the factory and any factory worker being able to hit the button, don't send this car out because the brakes don't work. If you have the philosophy that anybody in the system can hit the stop button, can hit the brakes and say, this is going to lead to a disaster, there's going to be a horrible event and we need to fix it, then you have a system that listens. If you have a system that is incredibly hierarchical, or each individual is just afraid of repercussions if they speak up, then you really can't help patients. So culture really matters. The best systems that I've seen are the systems that really constantly zoom out and say, when patient events are happening, what is it that we can do to improve our system? I'll give you an example. Centerstone comes up, which is part of the engage element that I was describing when I said we want to reduce access to lethal means within the zero suicide framework, is not just saying, well, you really should reduce, you got to get the gun out of your house, or whatever the case may be of your means. It's not just saying that, it's following through. So we may call your partner or somebody you live with and say, okay, so we met with Marjorie and we really she's mentioned she's at risk for suicide and we want to reduce access to lethal means. So what can you do? So we talk to your partner or somebody you live with. They've understood us, they've been educated, and they will report back to the clinician, yes, we've stored it in a lockbox, or we've moved it into a different house. And part of that, then, kind of knowing that you've dotted every I, is reducing that access to lethal means through that conversation and through ensuring that it happened. Centerstone had that in their workflow. We want to do that, but they were having a really hard time reaching families. They wouldn't call them back. And so to meet their indicator of, are we actually doing this, they had to look at their workflows and say, we can't have our clinicians calling until midnight. Like, something's got to give if they're not calling them back. So they actually took somebody from a different department and said, we are going to add to your workload that your job is going to be to call patients and get an answer and record in the electronic medical record that has actually occurred. And when they did that, they significantly increased fidelity to that piece of their model. But if they hadn't looked at it sort of systemically and in an aggregated way. And if they hadn't been listening to their clinicians who were like, we are trying, we are calling, but we can't reach them, we're exhausted, there aren't enough hours in the day. If they hadn't sort of tracked on their data how hard it was, as well as taken the really authentic feedback from their clinicians who said, they could have just said, call more, fix it, do better, right? That's kind of shame.
Right.
Adjust culture is, we are asking you to do something that obviously is kind of impossible. Like, yelling at you isn't working. So let's see how we can change the way in which we provide you support. And when they did, they had greater fidelity to doing that, which ultimately benefits patients because now they don't have access to the means to take their lives.
I love that. I am a big fan of Centerstone. So, and living in Nashville, and I mean, they're just really, really, really good people. I was on a call last week with one of their board members, Linda Rosenberg, who we've had on this series, and she's on that board, and she was just saying, she's like, I love that organization so much. Like, they're really doing good work. So this is a really good example and a nice opportunity to spotlight an entity that's doing it well. As we move into thinking about implementation or talking about implementation, we kind of understand now what it is. How does a health system get started?
So first, they just think that they have room for improvement. And we have a toolkit, zerosuicide.edc.org. It's a free, publicly available toolkit. We've really tried to make it very user-friendly. It covers a lot of the information that I'm describing and walks through the 7 components and with a lot more detail and helps people to get started. The first 2 tools that we often suggest that people use one is called an organizational self-study. That is really a needs assessment of the organization. And so all the things that I was just describing, these 7 components, we really break them down. We add things like the role of lived experience, because we think that that's a really critical piece of this model as well, that you really need to take into account. How does it feel to be a patient in your system? How does it feel to be somebody with lived experience for whom they may have had very traumatic experiences by healthcare in the past? So we created this organizational self-study on a scale of 1 to 5. We tried to benchmark, what do those different indicators mean? And then we encourage a system to sit down and take this tool as a leadership team and say, how do we think we're doing? What we've seen happen frequently is some people will say, sitting around the table will say, yeah, we do that. And other people at the table might say, well, that's our policy, but it never actually happened, right? So you really want to kind of unearth these conversations of these gaps in what we thought that, what do you mean that's not happening at every visit? We told people they need to, yeah, but there isn't time, or they don't know how, or they're afraid, or whatever. So you use the organizational self-study to really get a snapshot of how well you're doing today. It can help provide a roadmap of areas that you want to begin to engage and work in. And then the other tool that people can use kind of right out of the box is called the workforce survey. It is a tool that they can send to all of their staff in the system to assess staff's comfort and skill, their perceived level of comfort, competence, skill, and training in the different pieces of care that I was just saying. So it's a way to get back a snapshot as well of how does your workforce feel? Because if you say, yep, we're ready to go, we're great, but your workforce, only 30% of them say, yeah, I feel comfortable doing this work, then that should be a really strong signal to the leadership team that they have work to do. So those are 2 tools that are free, ready to go on the Zero Suicide Toolkit.
So the second one sounds like it goes a little bit more wide in the organization. On the self-study one, I'm curious, who's around that table? What kinds of people from the organization?
It's really, we hope that each organization will create a zero suicide implementation team. Okay. That team will, and that they'll even be the face of the zero suicide activity, so that, one person kind of is responsible and continually driving this initiative forward within the system. But the people that you want sitting around that table, it may or may not be your CEO. They may not have time, but really they're designees. It could be chief medical officer, chief nursing officer, chief clinical officer. But Also, you want people kind of who are seeing and engaging with patients every day so that you're getting real input about what's happening on the ground. You want to include things like IT at that table because the IT team has amazing feedback. Like I was talking a lot about, you want to embed these things in the electronic medical record, but you also want alerts. You want to know who's at high risk, who's on our high risk pathway because we've deemed them at risk for suicide. How will we know? How can we alert all of our team, whether they're coming in for a blood pressure check or they're coming in for something else, their next med check? How can we know that they're at high risk so that you use those tools like assessing or even just having a nice conversation with them? And IT has a lot of really great tools at their disposal that some of us who are clinicians don't really think about. You probably want your training director and then you want people with lived experience sitting at that table. So kind of 5 to 10 people who can really monitor and weigh in and drive the initiative forward. If you have researchers or a QI team or a risk manager, absolutely, you want them at the table because you need to have that feedback of how well are we doing. And having the risk manager, particularly in a hospital, they really want to know. I mean, they don't want to get sued. And they do want to meet their Joint Commission or their CARF accreditation. So having those individuals who are responsible for that, being aware that this kind of initiative and framework exists because it lines up with CARF accreditation and Joint Commission accreditation.
What about HR? Is there any benefit to bringing anyone from HR? You know what I'm thinking about, and the reason why I'm asking this too is suicide really affects everybody. So it could be patients, but it also could be the staff. It could be the healthcare providers, right? I mean, is this something that you're initiating internally and externally?
Yeah, I love that you brought that up. And it is when we work, we do a lot of training and consultation to healthcare systems as well. And when we work with them, we absolutely talk about that. And there's some resources on the Zero Suicide Toolkit as well. I think healthcare worker well-being is critical. How can you really take care of patients if you're struggling yourself? And you should have as much sympathy and support for whatever you're going through and honesty as you would expect of your patients. If you want patients to have a really hard conversation and be transparent and share where they're struggling, then we also need our staff who are doing this really hard work to have that same comfort in being just as transparent. But you are asking about culture. The leaders have to set that example. They have to offer the opportunities for staff to get their own mental health treatment, give them time off. They have to they can't have unrealistic expectations of people. I think that example I said of Centerstone where they couldn't reach people and they're working, super late and people aren't calling them back, at some point becomes an unrealistic expectation and it's a burden on the team. And I know that there's a lot of work underway right now in how do you reduce the burden of paperwork using AI, using other kinds of things, using other individuals who can record those conversations. I think we really have to think outside of, donuts in the break room and here's a video on stress management. That's not culture change. That's like barely a Band-Aid. We really have to use much more system-wide approaches. And there's a lot of great resources now in that place. The Surgeon General has talked about it. NIOSH, which is part of the Centers for Disease Control, CDC, just released a toolkit. And I don't know if you add some links at the end of this podcast, but I can send them to you because there's some great tools right now about worker well-being and changing. How do we message about that? How do we really set a culture that says you matter? We want to support you. And how do you start that right at the launch, right when staff comes in? And I think, as you said, having HR really speak to that and mean it. I was at an event last year where a system talked about they set up within their healthcare system, recognizing that people might not want to see the psychologist that they are in the room next door to. They contracted and had psychologists and psychiatrists and other clinicians immediately available for their healthcare workers, that they didn't have to leave campus. They didn't have to take a lot of time off, but they had them more immediately accessible and help to And that was just part of, I think, even in the first year of work, they made it sort of mandatory so that people could get used to it. Like really putting those things in place where a healthcare system says we don't just like walk the walk, right? Like, or talk the talk, we walk the walk too.
It's great. I'm excited, and I feel like I want to empower everybody who works within a system to do it, or to, to recommend it. You mentioned Centerstone as a good successful implementation. Are there other kind of stories of places that you've worked with or seen that you could share?
Yeah, I mean, I'll say one thing that we've tried to do is capture some of these stories. So, actually, one section of our toolkit, the Zero Suicide Toolkit, is outcome stories. And so, if you go to that website and you click on outcome stories, then you can kind of sort: are you a primary care? Are you a hospital system? Are you a tribe? What kind of system are you? And so you can look and see how did they accomplish some of the work that they did. So, for example, there's a tribe who did some great work, and not when they really embedded all of these practices, they reduced cost for their system as well, because which that also matters. And they were able to track, part of it had to do with where people readmitted to the hospital, but they were able to track that they had reduced costs because they had reduced the burden financially on the system as well.
Yeah, it's funny because you would think that it would cost more to implement it, not that you would save money.
I don't think, I mean, I think it costs a lot if you get sued.
That's a good
And
way to look at it.
and so I think that we have to think about, we've consulted, there are lawyers who do a lot of work in the suicide prevention world as well, and what they've said is if you use best practices and you document what you're doing, then you're very much less likely to be sued, even in the case where a person dies by suicide, right? People die when they have heart disease or cancer, and physicians aren't sued every single time. And part of that, I think, is a little bit of the transparency of, this is how I treat you. This is what I know. This is what I expect. You have to come back. This is how often you take your medications. This is what the side effects are. This is what might happen. And we're very transparent about offering hope, but also working with the patient and their family about what to expect. And unfortunately, sometimes people still do die of, heart disease or cancer or other things. They're not sued. In mental health, we historically have had, I think, less transparency. And so as a result, families, I think, sometimes feel like, I don't really know where this is going. They don't understand their treatment plan. Is this forever? Am I going to see you forever? How, like, these skills that you're teaching me, like, how long should it take? What is this? What should I expect? How will I know that I'm getting better? I think those are fair questions that people should be asking their providers, and providers should feel comfortable answering. They should have, and this is what I do. I screen you every time you come. If you don't come if I know that you're at risk for suicide, then I'm going to do these extra things for you. We're going to do a safety plan. This is what the rationale is for a safety plan. We're going to talk about lethal means, and here's why. We're going to use treatment. Here's what I know about these treatment approaches. I think if we explain along the way what it is, and then we document that we did those things, then patients and their families feel heard, and appreciated and valued. They come back to care. We know in mental health that people often drop out of care after 1 or 2 visits because they think, I didn't really like the person, or I don't really feel like they can help me. So I do think it has to go both ways. We have to offer hope to people. I know I'm comfortable treating this. This is what I'm going to do. We're a team. We're going to peel back this onion of your thoughts of suicide together. And here's how I'm going to help you to get better. And I'm going to hold your hope when you can't. But I do have hope because I've worked with other people like you. And so the more that we do that, I think, and we're honest, the less likely we are to get sued.
I love that. I'm going to hold your hope. That's really good. And it makes a lot of sense in a very practical framework too, that you're giving people some guidelines, the provider too, right? The practitioner, some guidelines of how to address it. And I liked the analogy you gave earlier about the, oh, I have to fill out this form and, don't worry about it. Just, have you had any thoughts of suicide? And you sort of like guiding the, the person there. That doesn't create a safe place for that person to share. And so I think so much of it is like we're constantly need to be working on ourselves and getting better as clinicians as well, so that we can deliver that best care. We started today talking about the different cultures and what the research has learned or hasn't learned about these different cultures, but we do have these marginalized communities. How does that work in implementation?
Yeah, I mean, I think that it's a framework with 7 components, but how you adapt it within the culture and setting in which you work, I think are things that we have to take into account, right? It's not going to look the same to adopt zero suicide in an urban setting that it is necessarily in a rural setting, even if it just has to do with access to providers, right? If you've a large census of mental health providers on every block versus a wait list of 6 months, or seeing somebody who lives 90 miles away and they're probably not going to go, then I think we have to think about what are other opportunities to fill those gaps. Is it telehealth? Is it the faith community? Is it bibliotherapy and other kinds of online resources? I think there are cultures and settings that have, I think we have to take advantage in different settings that there are individuals who can be tremendously helpful. I think not everybody people can do great work, not with therapists, right? There are amazing faith leaders out there as well. And I think engaging that, and are you talking to your faith leader, and is that helpful? I think we just need to be open that in tribes as well, that there are elders and there are beautiful systems set up that support individuals. We want to pull those in, but we don't know what we don't ask about, right? I appreciate that, I am a middle-aged white woman. And so I don't know everything that's available and accessible if I was treating somebody who was in a tribe. But asking them, tell me more about what gives you comfort. Tell me more about how your culture understands suicide. Tell me more about systems in place where others around you might get some support. I think we have to ask more about how culture plays a role for people, and also just be humble enough to know that we don't know everything.
I think that was a beautiful answer. Now, thinking about the practitioner in practice, what can they do to deliver better care to a client that might be at risk for suicide? And what if their system, or they're either kind of what we call a single shingle, they work for themselves or a small group, or they're with a health system that has not adopted zero suicide?
Yeah, I think for sure the practices, particularly the clinical components that I described at the beginning, are available even to individual providers. You can, the patient health questionnaire, the PHQ, the ASQ, the Columbia Suicide Severity Rating Scale, those are free. You can find them online. And so you can start using those if you're not using them now. There's the Stanley Brown safety plan template. I think you might even have that in your library with Psych Hub. So I think that those are accessible and usable. There's Craig Bryan created a crisis response plan. I think that's free online. All of these are things that individuals can use. And then thinking about treatment, and do you have training in DBT or CAMS or one of the other evidence-based models? You don't need your system necessarily to train you if that's something that you can access on your own. I think as an individual provider, some of the takeaways that happen with an individual anyway are that concept of really offering hope and transparency. And again, you don't need your system leadership behind you to measure that you're doing that, for you to be empathic, for you to understand that somebody may have had very traumatic experiences when they went to the emergency department before, or previous clinicians may not have really helped them. I know a woman who we worked with for a very long time. She was one of our speakers. She unfortunately passed away, not by suicide a couple of years ago. She is a woman who had her own history of sexual abuse and substance misuse. She had been in treatment. She actually is somebody who's she's Latina. She had been hospitalized multiple times for suicidality while she was in treatment with a provider. And what she said was, I was the best patient. I showed up at every appointment. I talked throughout my therapy, but my therapist never asked me if I was having thoughts of suicide. She said, we talked about my trauma history. We talked about my substance abuse. We talked about my family and my relationships. She said, my therapist never asked me if I was having thoughts of suicide. So I was the best patient. And then I would make a suicide attempt and go to the hospital. And the therapist thought that was out of the blue. I had no idea. It must be impulsive. The woman I'm speaking about was like, I knew I was struggling with thoughts of suicide, but nobody asked me. And so I don't know how therapy works. I'm supposed to just tell the therapist that they seem like if they wanted to know, they would have asked me.
Wow.
And so she didn't tell the therapist. And it wasn't until she ultimately, after multiple hospitalizations, got started on DBT and then ended up getting into a wonderful DBT program and really began to resolve her suicidality. But I thought that was such a poignant example of this person who the woman thinks she's doing everything right by going to therapy. The therapist thinks they're doing everything right. And yet there was this tremendous gap. So I think one of the biggest messages to a clinician is you have to ask. Your patients aren't going to tell you. You have to ask directly. You have to ask at every visit. You can't say, but I asked at their intake 6 months or 2 years ago and they said no, because people's life circumstances change. So get comfortable with asking and make that part of the culture of you as a therapist, that this is just what we talk about because I need to know, and I have skills and interventions I'm going to employ if you say yes, because that's what I do.
It's such a good point, Julie, because it's also why people are there. They want to get better. So it's hard but important to ask the right questions. What are some other challenges that practitioners might have besides, just asking those poignant questions in a very empathic way about suicide, not in a leading way?
Yeah, I mean, I think we kind of touched on this, which is most of us didn't have this training in graduate school. And so suicide can be very scary. And so I think if you can access training like this, but also get continuing education credits in suicide specific interventions, then hopefully that can reduce any anxiety that a therapist might have. Because I think you are going to have people who struggle with thoughts of suicide, and avoiding it isn't going to help the person at risk. So I do think that first, it's fair to just recognize it. It is scary. Nobody wants to have a patient die by suicide. So figure out, how can you get support? How can you get supervision? How can you be honest about where your own gaps are in your own knowledge? But it's not enough to say, well, they'll just tell me and I'll refer them if they start saying they're having thoughts of suicide. I think if you have a really strong relationship with the individual, then you are best suited to be able to do therapy with them about it. But use the tools that exist. Use proper screening tools. Use proper safety planning tools. There are so many even free resources about how do you do safety planning, that you can watch some videos and learn. And even that can really help to stabilize a person. So just really begin to explore what's available. I think I think one really important myth, and I think most clinicians know this, but it's important to say, is talking about suicide doesn't put the thought into somebody's head. Right? We know from the research that asking directly really matters and helps, but asking directly for somebody who wasn't thinking about suicide doesn't make them start thinking about it. They either are or they're not. But the idea that you're setting a foundation of this is a safe place to talk about things that are really tricky, I think really just improves the relationship between a patient and their therapist and makes it even more trusting and comforting.
I think so too. We often hear that therapists don't want to treat suicide or specialize in it because the cases are so difficult and they're so hard. And if there's been, past experiences, past attempts, it makes it harder, or they don't feel like they have the confidence, or they're just afraid of them. And we've heard this quite a bit. And as you know, it's such an important, so important that all practitioners really grasp these skills. Do you have any tips or anything to share about to help them overcome their fear or give them the confidence that they can do this?
Yeah, I mean, I think lean into all these best practices that exist, lean into your colleagues, but you are going to have people at risk for suicide, and these treatments work. I mean, a very small number of people die by suicide, but 12 million people are thinking about it, right? 49,000 people died, 12, 13 million people are thinking about it. Lots and lots of people are thinking about suicide. We want to reduce that burden. We want to figure out why. What's the underlying cause? It gives you room to open up and talk about what are their causes for their thoughts of suicide. We also have to accept that some people are going to chronically live with thoughts of suicide, but it doesn't necessarily mean they're going to make a lethal attempt. So I think that, even sending people to the hospital, I think, we didn't touch on this, but this is a really important point. Sending people to the hospital is not treatment. It's
Mm-hmm.
almost back to those, like, it's a no suicide contract. Like, well, we'll sign it and then we don't have to worry about it anymore. It's sort of that same idea of, oh, if I send them to the emergency department, I'll get like a slate of, they're doing well. They can come back to me and we can go back to talking about other things. That's not true. Most people aren't going to get admitted if they go to the hospital, and they're getting stabilization, but the same underlying causes that gave them those thoughts of suicide are still going to be present. Hospitals don't treat, right? You can't treat somebody in 5 days out of their thoughts of suicide. You can stabilize them, medicate them a little differently, but
Mm-hmm.
they're coming back to you if you're an outpatient provider. So figure out and it's very traumatic going to the hospital. So to the best of your ability, really understand that this is a patient who you care about and who has a relationship with you. So how can you use all these tools to your advantage? You can be honest, like, I am worried about you and I'm worried about some of the things you're telling me, but we're going to navigate this together. I have hope. I have these tools that we're going to use together, but I absolutely believe that you can do better, but we're going to navigate this together. We're going to use, we're going to look at the drivers of your suicide. We're going to learn how we can reduce the drivers of your suicide together through meeting, on this time schedule. And I really value your honesty with me, and I will be as honest with you as I can be as well.
Thank you for saying all that. I think those are great, great tips. Are there crisis resources for the therapists that they could tap into that you're aware of?
Well, there's crisis resources that should be shared with patients, which is the nation's crisis and suicide prevention hotline, which is 988. Anybody can call that. It's available 24/7, no matter where you are. Some are volunteers, some are not, but anybody can call that for immediate support. Even a parent who's worried about their kid, a clinician can call that. It's not a mental health network to support other mental health clinicians. It is a crisis line. They determine if they should send out mobile crisis, but it is something that you should be referring your patients to call to support them in between appointments as needed. There are, to my awareness, certain settings like primary care networks where you can call in. I know Massachusetts has a really good one. I think there's one in Maryland where you can call other primary care networks or psychiatry networks and get some support. I don't have numbers off the top of my head or those networks available, but I would look into that as well and say, are there some systems in place where clinicians can call for support to ask questions of other clinicians. Certainly getting your own supervision is needed. Other kind of professional groups, membership organizations. There's the American Association of Suicidology, AAS, with a really active listserv and network and annual conference where you can definitely get support by other members doing this really hard but incredibly valuable work.
That's great. That's so great. What about the future? What do we got? Like, where do you see this going? Do you have any places? You guys are kind of at the forefront of all of this. What are your thoughts about where the whole space can go?
Yeah, I mean, I think the field, suicide prevention, as I said, I've been in it for like 25 or so years. And it's more like the last 5 years have been this like super fast moving train where the first 20 years were a little bit more like, we're a little slower. The use of technology in inpatient therapy, healthcare systems, data analysis, data prediction, I think is going to be tremendous. And we have to learn how to partner well with our technology friends. I think that they can serve a lot of needs that we may not be as aware of. I think that there's a lot of support in the country right now for suicide prevention. People are much more willing to talk about it than they were years ago. I think we have to keep reducing the stigma. And I think that we're successfully doing that. The role of lived experience and talking much more openly about suicide is something that I'm seeing more and more than ever before. And part of that's ourselves too, not just our patients, but also our own families, and just kind of, yep, my kid's in therapy and my husband had prostate cancer, right? Like equalizing these things so that the more we talk about it and can use one another, I think is happening and will continue to happen. There is a new national strategy being released in just a few weeks in the country. So the country has a national strategy for suicide prevention. This is the third version of that. It is being released by the federal government in just a few weeks. And so people should be by the time you see this podcast, it'll already be out there. So look for that, because it really is a roadmap for what we can do in the next 10 years. And it's really a compilation of best practices across all sectors, settings, ages, demographics. It's got a really heavy focus on equity, a really heavy focus on lived experience, and a really heavy focus on measuring what we're doing. So are we doing all these things that we now have available to us, and how well are we doing them? I think the next 10 years, one of the key pieces of our work is we've built a lot of awareness. We've even built up a lot of evidence-based practices, but now we really need to track on how well are we using all of these practices that exist, and continue to pull new people into the conversation. We can't solve suicide prevention in the bubble of mental health, because the vast majority of people don't touch mental health. Even when they have thoughts of suicide, they look elsewhere. So we think we need to think, who else can be at the table? What other kind of community, faith, schools, workplace? We need to come out. So, we're not going to solve it on our own and therapy our way out of it. So we really do need to kind of think about who else we can partner with.
I'm hopeful for that bright future for all of those different reasons. And I think it's so true about the awareness. And then, we've done a great job in mental health awareness campaigns and anti-stigma campaigns. And then we've done a really good job in researching evidence-based therapies. Now we have to put them into practice and measure them and figure out and then change the incentive models so that we can get higher reimbursement for quality care. But
I think that's huge. We need our psychiatrists and psychologists and other mental health clinicians to be paid to do this work. So we really do need the ear of the payers to say, mental health parity is really critical. And it ultimately, we know when people are struggling with mental health, it really impacts their physical well-being as well. So, but I think all of those conversations are much more tangible today than ever before. So I'm hopeful.
official question I have for you is let me start that sentence over again. So what recommendations do you have for practitioners who might want to build up their toolkit and learn more?
I hope people will visit the Zero Suicide website. I think we've really heavily curated that to help people get started, whether you're in a system where you can adapt and adopt zero suicide for your healthcare system, or even whether you're a clinician and you just need to drill into those clinical pieces. The zerosuicide.edc.org website, I really hope you'll take a look. I think that you'll find a lot of things that you may not have known about, you may not have learned in graduate school or through continuing education, but that hopefully will give you a roadmap for how to take care of your patients. We do a lot of webinars. We do a lot of other videos and resources that we dump in there to try to give you sort of hands-on moments to learn what does this look like, to be operationalized. So take a look and then give me feedback. Let me know if there's things we're missing. I welcome feedback too.
Perfect. And I'll piggyback on there. A selfless plug here for Psych Hub is that we also have quite a bit of suicide prevention training as well. CBT for suicide, which we did with Barbara Stanley and Greg Brown, and also CAMS as well. So I think it's a collection of all these things can make a big difference. So Julie, this has been amazing. In closing, we've discussed evidence-based suicide prevention treatment through zero suicide and so much more. What is the number one thing that therapists should take away from this?
Is this on our list? The number
Yes,
one thing.
in closing, we always ask this question.
I think the number one thing is you are doing really hard work every day, but there are tools to assist you. There are resources to assist you. Don't be afraid to learn more about suicide prevention best practices. And I think one of the most important things to think about when you're working with somebody at risk for suicide is empathy and hope, right? Somebody being seen and heard, making eye contact, taking them seriously, giving them a really unique experience that maybe they didn't have before, that you are listening and care and can help them, and that you are offering hope both through through what you do physically and the way you look at them, but also through how you describe your treatment approach and your treatment strategy is so powerful. And for so many people, they've never had that. They may not have had, this type of quality interaction or intervention before. So all of those things really, really matter. So lean on that, lean on those clinical skills, but also lean on the evidence-based practices, and know that there are other supports available. Refer people to 988, the crisis line, when you feel that they need additional support outside of the hours that you're available.
This was fantastic. You exceeded my expectations and they were high. Where can our listeners learn more or get a hold of you if they want to?
So if people are interested in learning more, they can certainly email me at jgoldstein@edc.org. They can find me on LinkedIn, Julie Goldstein Grumet. Follow me. I try to post a lot of current events. Also, I'm the director of the Zero Suicide Institute at EDC, and the Zero Suicide Institute provides training and consultation in implementing zero suicide. And you can find us at zerosuicideinstitute.com. We are available. A lot of systems get started on this journey. They use the toolkit, but then sometimes they say, I think we need a little bit more streamlined support and help. So oftentimes they reach out to us. So please go ahead and feel free to reach out there as well.
Thank you so much for joining us. Really appreciate it, and can't wait to continue to follow all of your experience, expertise, and where you're going to take this whole space.
Thank you so much for having me. It's really a pleasure, and enjoyed spending this time with you.
Thanks so much for listening to Therapy Cafe, the future of mental health. For more information and resources regarding today's topic, please take a look at the episode show notes. If you'd like to obtain continuing education as a psychologist, counselor, social worker, or therapist, you can purchase a 1-year subscription to Psych Hub's learning platform. Once you're signed up, you'll have access to earn CEs for this and every Therapy Cafe episode. Plus, you'll have access to our existing library of over 100 evidence-based practice continuing education courses created by expert clinicians. Go to psychhub.com/sign up for more information.